Hello, Michelle, and hello, everyone. Today, we are here for another concise conversation about magnetodynamic technology with practical information for everyone attending. Let me start with a direct question. What does magnetodynamic technology mean to you, and how has it changed your everyday clinical practice? For me, magnetodynamic technology has been a major revolution. Above all, it has simplified my daily work in oral and implant surgery. The key word is simplicity. Simpler procedures, simpler management of the operating table, and fewer instruments to prepare when I travel for consultations. When we work as consultants, we do not always know what we will face. Instead of carrying countless instruments and kits, one device with interchangeable inserts lets us manage many situations. It covers almost all maxillary surgery and much mandibular surgery, especially implant and extraction procedures. It greatly reduces the need to decide which equipment to take to each case. Let me share the screen and show a few radiographs. These simple clinical examples demonstrate both the practicality and the versatility of magnetodynamic technology. Here is a straightforward implant case with approximately 6 millimeters of residual bone. With the magnetic mallet, we can prepare the site and perform a small crestal sinus elevation. Primary stability is excellent, so we allow the site to heal. The sinus membrane remains elevated, and over the following months, the space gradually mineralizes and new bone forms. The procedure still requires planning, but it is both simple and fast. Here is a 2-year follow-up. In another post-extraction case, divergent molar roots leave an interradicular septum that can become an ideal implant site. There is also maxillary sinus pneumatization. Using the magnetic mallet inserts, we perform an atraumatic extraction, prepare the site, place the implant, and review the result after 3 months and after loading the crown. Bone develops around the implant threads. The radiograph is not dramatic, but the ease of placement, the post-operative course, and the minimally invasive atraumatic approach are the real advantages. The innovation is the simplification of procedures we already performed. It makes advanced oral surgery more accessible. If you have questions, write them in the chat and I will present them. We also know you as a creative surgeon. In professional discussions and the cases you share online, you often take an unconventional direction while still achieving remarkable results. That creativity comes from the ability to displace and shape bone. We can move it according to the requirements of each clinical situation. It is a little like Robin Hood. Take bone from where there is more and move it to where there is less. This can reshape the alveolar ridge and avoid more invasive approaches. Those alternatives may be more expensive for the patient and require longer healing. With thoughtful use of the instrument, we can solve everyday problems. Recently, for example, I placed an implant and then reconsidered its position. It was an immediate implant in an upper molar socket. I removed it, moved slightly distal and vestibular, and began preparing a new site in the preferred position. The displaced bone closed the previous preparation, and I could place the implant again with good primary stability instead of leaving one large defect between adjacent preparations. Otherwise, I might have lost primary stability or had to discard the implant and use a larger one. This is not improvisation. It is applying the physical principles of magnetodynamic technology surgery to routine clinical situations. Another example is LMSF, local management of the sinus floor. This elderly diabetic patient wanted to chew better and presented with a classic triangular ridge, very narrow at the coronal level. The maxillary sinus was also highly pneumatized. Conventionally, we might have required ridge splitting or GBR plus a sinus lift, all more invasive and traumatic procedures with longer healing times. The patient's diabetes was poorly controlled. We entered with the insert, angled mesially, fractured and displaced the cortical plate, and still obtained a prosthetically acceptable implant position. We placed these conometric connection implants deeply, beyond the first very thin millimeters of bone, through an envelope flap of about 1 centimeter. This is the result at 3 months and after 4 months of loading. The distal sinus gradually begins to mineralize, and at 6 months we see complete remineralization, achieved through a crestal incision of only a few millimeters. Here is another quick case involving a canine. For an immediate implant, the vestibular wall is extremely thin and almost absent. The sinus is also pneumatized, creating a double problem. With the magnetic mallet, we begin with an atraumatic extraction. We place the implant while reshaping the maxillary sinus to obtain the correct position. A small GBR was also performed. In the immediate postoperative radiograph, the small bone fragment has been fractured and displaced as planned. This is the healed and finalized case. Most interesting is the complete reformation of the previous maxillary sinus wall. Let me show another creative application. Luca Boschini and I also work on dental transposition cases. A canine positioned very high near the maxillary sinus would often require referral for a more invasive surgical removal. Using the magnetic mallet and split inserts, we make small controlled cuts, mobilize a limited bone block, and remove the canine. This also led us to ask what else the instrument could achieve. A computer-designed replica of the canine root was produced by laser melting. It follows the root form and is used in the alveolar process previously prepared with rotary instruments. This video shows how the recipient's site is shaped precisely. In the end, we can guide and reposition the dental transplant in the planned direction. I will move quickly. The follow-up shows the result several months after the surgery that Luca Boschini and I performed together. The patient is completing orthodontic treatment. These creative ideas all begin with the same principle. Bone can be modeled and displaced according to clinical need. Creativity remains in support of sound clinical treatment. The instrument can help every clinician, even without pursuing such unusual applications. It is valuable to think differently while still performing controlled, evidence-based surgery. How far do you think this technology can take us? What have you learned from it? Where could it develop next? And what risks must we recognize? We have discussed its benefits, but from your perspective as a practicing clinician, what are the actual limitations of the technology? The first revelation was understanding how extensively bone can be remodeled. I began implant dentistry, imagining bone as a fixed structure into which we drilled an implant site, or from which we removed a tooth. A well-anchored tooth seemed removable only by taking away the surrounding bone, and an implant site seemed possible only by drilling. Magnetodynamic technology showed me how bone responds to mechanical stimulation. Bone can change shape, and that transformation also changes its physical, mechanical, and biological properties. A very interesting article on this subject will be published, and I encourage colleagues to read it. This opens a broad new horizon, but it must be evaluated carefully. Bone has limits to its elasticity and remodeling capacity, so appropriate case selection is essential. The magnetic mallet should not be used indiscriminately in extremely cortical bone. Otherwise, unwanted fractures or other complications can occur because that bone cannot be safely modeled. A valuable future development would be a centering or guided system for osteotomes. Because the inserts can displace bone, the clinician currently relies strongly on tactile sensitivity and hand control. The operator must direct the insert to move bone from one side to the other. A guidance system could make this more straightforward, particularly for less experienced clinicians still building confidence. Another promising application is the all-on-4 concept. In atrophic cases, implant placement is often considered difficult or risky. Magnetodynamic technology does not make these cases simple, but it can simplify them. It also improves control of implant parallelism. Let me share the screen again and show another example. I call this concept the bone-sharing wave. We should no longer think of moving bone only at the exact implant site. Instead, we can remodel an entire alveolar process, or part of it, by using several inserts at the same time. This short Osseotouch animation illustrates the concept. For a long expansion or a small sinus elevation, simultaneous inserts distribute the stress produced by each impulse more evenly across the alveolar process. In the image, the handpiece might appear to contact the adjacent insert. Using the angled bayonet adapter solves this limitation. By rotating the bayonet adapter, we can activate the inserts sequentially, verify parallelism, and prepare two parallel implant sites from the very beginning. This case combines ridge splitting and expansion. Here is another clearer surgical video. It shows horizontal atrophy around the first premolar site and the resulting need for controlled ridge expansion. At the molar site, we need both expansion and a small sinus elevation. We start with ridge splitting and proceed quickly to demonstrate the principle. We perform the split even where a sinus elevation is needed. First, we gain horizontal width with the split series inserts, then begin simultaneous implant site preparation. The ridge remains expanded while we control the parallelism of the two implant sites. Progressive and simultaneous penetration lets us expand and elevate the sites in a coordinated way. Rather than driving the first insert to its endpoint Before moving to the second, we alternate impulses between them. This creates the expansion wave that I call the bone-sharing wave. In the end, we expand the ridge, elevate the sinus, and place both implants. At the first site, we performed expansion only. At the second, expansion and sinus elevation. The same control is useful in full arch cases. In full arch treatment, we must control both parallelism and prosthetic emergence. Here, all the inserts are positioned to prepare the implant sites simultaneously, whether expansion or elevation is required. We then place the implants with close control of their prosthetic emergence, which greatly facilitates the selection of the final prosthetic components. This is another practical, everyday benefit. For some clinicians, this is already routine, while for others, it is still new. A question concerns future guidance systems and the development of dedicated inserts. We have been working on these developments for several months, and further news is expected in the spring. Stay tuned, because guided control is an area that interests me greatly. A company must keep listening to clinicians and understand what they need. That dialogue, supported by clinical evidence, is ultimately what drives successful product development. Magnetodynamic technology is now an important part of your professional activity, and you teach courses in Italy and elsewhere. Interest has grown strongly over the last 2 years. These courses are for clinicians who want to understand the different applications of magnetodynamic technology. A full immersion program in a beautiful location such as the Gargano would be especially valuable. It is not a single course, but a structured pathway for clinicians who want to approach oral surgery. This is now the second edition. The pathway has 3 main modules. The first covers basic principles, sutures, and straightforward extractions with the magnetic mallet. The second covers impacted teeth, including third molars and other inclusions. The third, more advanced module covers dental transpositions. Together with guided surgery, the use of patient-specific replicas with the magnetic mallet has transformed our approach to these cases. Additional events will be added with the expanded teaching team, and details will be available online. We are also developing a new project specifically for magnetic mallet users. The idea is to create meetings where clinicians who already use the magnetic mallet can compare advanced techniques and explore individual applications in greater depth. We divided the program among specialists. Luca Boschini will examine dental extractions in all their aspects, alongside contributions from other experienced clinicians. Another module covers the maxillary sinus and the full range of crestal sinus elevation procedures that can be performed using magnetic mallet osteotomes. Dr. Filanino will address split crest procedures and ridge expansion. Every topic combines theory with hands-on practice. We will also discuss full arch treatment and the possibility of completing an entirely magnetodynamic technology full arch protocol with its practical advantages. Let me show one complete case. This full arch example gives a more complete view of those advantages. building on the shorter clinical examples we have already seen. This is a challenging skeletal Class 3 case. The anterior teeth had supported a bridge, but the bridge failed and was lost. There was severe bone loss around the canines. Clinicians who perform immediate loading know how important the canine pillars are for managing this type of rehabilitation. The CT images show the remaining incisor bone. There is a marked sagittal discrepancy between the bone and the planned crowns. This creates a substantial cantilever and potentially dangerous forces. Further posteriorly, the anatomy becomes even more difficult. Beyond the canine defects, both maxillary sinuses are pneumatized and there is almost no usable bone. In planning and all on 4, the CT shows severe destruction, particularly around sites 13 and 23. Placing implants is difficult, and moving distally brings us close to the maxillary sinuses. We must find enough bone for predictable, safe placement and good primary stability. We want to avoid opening the sinuses or pushing unnecessarily toward the posterior maxillary limit. The initial plan placed the implants close together, creating prosthetic concerns. Some bone remains in the maxillary tuberosities, but this is not ideal bone for immediate loading. Here, the magnetic mallet becomes especially helpful and changes the treatment plan. We need strong primary stability and tilted implants around sites 15, 14, 24, and 25, positioned as distally as possible while remaining safe. After flap elevation, the severe canine defects are evident. In the anterior region, we use drills. Posteriorly, the sites are prepared entirely with the magnetic mallet, following the available bone density without rotary preparation. The implants are placed with the premolar implants positioned as far posteriorly as safely possible. The tuberosity implants are also visible and are inserted very simply with a straight tip. By condensing the bone without drilling, we obtain enough primary stability to place the impression copings. A replica made from the aesthetic try-in helps us capture the impression accurately. The impression is converted into a provisional restoration. On the day of immediate loading, post-operative swelling is minimal because flap elevation was limited to what was strictly necessary for insert access. We avoided large flaps, did not open the maxillary sinuses, and did not elevate the entire palate. We created only enough visibility to work safely and sensitively with the inserts. At site 14, the implant was placed very close to the sinus without drilling into it. Inserts of progressively increasing diameter displace the sinus floor in a controlled manner. This is the immediate loading panoramic image and the 6-month result. The sinus has repositioned around the implant. Even the tuberosity implants, which some might expect to fail, are functioning very well at 6 months. This panoramic radiograph is the 2-year follow-up. I wanted to show this case because it brings together many applications in a single difficult situation that magnetodynamic technology helped us simplify. Let us take a few questions. A clinician asks about the effective advantages of black ruby inserts compared with traditional osteotomes. I recommend another magnetic mallet shot with Luca Boschini, who designed these inserts and discusses them in detail. Having tested them early, I find their main advantage is penetration during implant site preparation. For preparing a site, black ruby inserts offer a major advantage. For sinus elevation, I often prefer traditional flat-ended inserts because they let me push the sinus floor and grafting material in a controlled way. When the cortical floor is hard, a spherical insert can simplify initial deformation and fracture. I may alternate a black ruby insert with traditional inserts used to elevate the site and advance grafting material. The principal design difference is the double taper, a penetrating tip followed by less conical walls that slide with less resistance, particularly in relatively dense D2 or D3 bone. I invite everyone to watch the available videos in which Luca explains the system in depth. Further educational material and webinars are also available on our website. We are also returning to live courses. A special location in the Gargano, such as Baia delle Zagare, would let everyone learn together in an ideal setting. A 3-day residential course would give the group time to stay together and complete the necessary practical exercises without constant travel between locations. The program would include extractions, sinus elevations, ridge splitting, and full arch preparation. These subjects require 3 days of practice, with time for participants and their families to enjoy the location as well. Another question concerns sinus elevation. Do we fracture the cortical plate of the sinus floor, displace it, or both? The answer depends first on the direction of the approach. With an oblique approach, the insert works like a shovel in sand and displaces the wall. When working along the implant axis, our usual aim is a controlled fracture. For a major elevation, fracture is more likely. If only 1 millimeter is needed, the impulse may simply deform a thin cortical floor and create a small elevation without complete fracture. A similar principle is sometimes called the clip technique. Aggressive implant threads can first deform, then fracture and elevate the sinus floor as the implant is advanced. Today, I usually create the controlled fracture with the magnetic mallet. After that, appropriate condensers can advance the site, and an implant with suitable geometry can be placed without losing rotational stability. So both outcomes are possible: deformation and controlled fracture. I hope that answers the question. Let us thank everyone. Our planned half hour has already passed. Thank you very much, Michele. We kept the format concise while covering a great deal in this magnetic mallet shot. We will now say goodbye to everyone. Thank you all. For further information, you can contact me directly or speak with Osseotouch. Best wishes to everyone and have a good evening. Thank you, Manuel. Thank you. Goodbye, everyone.